Thank you, Evgenia. Hello, everybody. It's nice to be again with you, even if it is virtually. My topic is diabetic nephropathy. I will try to cover some aspects of diabetic nephropathy, saying what is important. As Mohammed has already talked something about the hypertension and microvascular complication, we all know that diabetes is a widespread pandemic, even much bigger than COVID in itself. The last figure is about 463 million people with diabetes living in the world on 2019, and this figure would go up to 778 million people in 2030, and more than 700 million adults will live with diabetes on the world on 2045. The problem is not diabetes in itself. It's mostly related to the chronic complication of diabetes, where diabetic nephropathy is a very common and very serious complication, counting for more than 20% of people with diabetes. And we all know that lowering 1% glycated hemoglobin from the actual glycated hemoglobin, we can reduce on 14% the number of myocardial infarctions, less than 21% death related to diabetes, and less than 37%, more than 1 in 3, microvascular complications, including diabetic nephropathy. What is diabetic nephropathy? It's a progressive increase in proteinuria in people with long-standing diabetes, followed by declining function, which can eventually lead to end-stage renal disease. So diabetic nephropathy in itself, it's just a part of end-stage renal disease. And we can see that the number of people with diabetes, it's more than half of the people in end-stage renal disease. And these are figures from all over the world. Some of the risk factors for diabetic nephropathy are poor glycemic control, hypertension, genetic predisposition, hyperlipidemia, smoking, long disease duration of diabetes, and ethnicity. Some words about the epidemiology. Proteinuria would be present in from 25 to 45% of type 1 diabetes, especially after 15 years of diabetes duration. And the prevalence of microproteinuria, it's about 25% after 15 years of diabetes in type 2 diabetic patients. And year incremental in incidence of microalbuminuria is from 15 to 25% in bad control of risk factors. And we can see a trend in the general population in several countries, like it is in Australia. We can see a continuous increase in the number of people in renal failure due to diabetic nephropathy, and the same figure is present in United States. I'm pretty sure that this could be all over the world. Most of you are very familiar with stages of diabetic nephropathy, which are not different from chronic kidney disease, beginning with glomerular hyperfiltration, continuing with thickened and expanded mesangium, microalbuminuria, macroalbuminuria, and end-stage renal disease. And in this figure, we can see more clearly the stages of chronic kidney disease in close relation to anatomopathological changes to the kidney due to the diabetic nephropathy, beginning from the basement membrane thickening and mesangial proliferation to advanced diabetic glomerulosclerosis, which is the last stage of end-stage renal disease. Cockcroft formula for calculating glomerular filtration rate, it's very useful to really evaluate the stages of chronic kidney diseases. It is more important than measuring the serum creatinine. In a study made in the United States with people of different ages, gender, and ethnicity, we can see that the same level of serum creatinine in black people of the age of 20 is different for females and males of the same age. So for some of these people could be the stage number 1, For some of them could be the stage number 3 of chronic kidney disease, and always the serum creatinine is the same. That's why it's more important to measure or to calculate the glomerular filtration rate. Who, how, and when should be screened? It is important to measure the blood pressure in every office visit with a target of less than 130/80 millimeters for people with diabetes. And we need to screen all type 1 diabetics with diabetes developed pre-pubertally from puberty, and for people with type 1 diabetes developed after puberty 5 years after the diagnosis. And for type 2 diabetes, since the moment of diagnosis, we need to screen for the presence of microalbuminuria, or at least to see if there is any stage of chronic kidney disease. But the problem is, do we need after that to screen every year, or we can stay for longer period of time? What is important when we screen for diabetic nephropathy, it's important to screen at the same time for retinopathy, because there is no possibility that we have a real diabetic nephropathy without any changes on the fundus. So without any sign of diabetic retinopathy, it's almost impossible to have diabetic nephropathy. How can we screen? It could be done through albumin creatinine ratio with values of more than 30, it's microalbuminuria, and more than 300, it's clinical albuminuria. Or we can collect the urine of 24 hours. But it is important, this could be done in absence of infections, strenuous exercise, or hematuria, and begin the screening after 5 years of duration for type 1 diabetes, and since the moment of diagnosis for type 2 diabetes. We can use several methods for measuring microalbuminuria, beginning with albusticks or micral test strips, as we said about albumin creatinine ratio, or with the 24-hour collection of urine to measure mostly the macroalbuminuria than microalbuminuria. The problem is that when we are at the stage 3 of chronic kidney disease, there is an increase of cardiovascular mortality of about 20%, which is 2 to 3-fold higher risk than in people without diabetic nephropathy. And for the stage 4, this is about 24%. And for the stage number 5, or the end-stage renal disease or dialysis, the risk is about 45%. So the people with diabetes, and especially with chronic kidney disease, are in much higher risk for cardiovascular mortality, as we can see in these slides, that even the cardiovascular event rate are much higher with the declining of glomerular filtration rate. But when we speak about diabetic nephropathy, we could keep in mind that diabetic nephropathy is just a part of chronic kidney disease, and people with diabetes could have also other problems directly related with hypertension, renovascular hypertension, or other chronic kidney disease. And we must consider non-diabetic renal disease, so it is chronic kidney disease but not really diabetic nephropathy, in the absence of diabetic retinopathy, if we have a rapid decline of glomerular filtration rate, if we have refractory hypertension, or if we have other diseases. And in these cases, it could be interesting to use the renal biopsy if the diagnosis is in doubt, or if other kidney disease is suggested, or if atypical features are present. What is known about patients with chronic kidney disease? We need to address cardiovascular risk to prevent the early death of these patients, to slow the progression of renal disease, and to delay the need for dialysis or for transplantation. and to avoid harm through using of medicines that could be contraindicated in people with chronic kidney disease, and especially avoiding hypoglycemia. What is important is that first of all we need to control diabetes, because these people are first of all diabetic patients. So without a better control of diabetes, we cannot delay or prevent diabetic complication. So we need to have a glycated hemoglobin below 7% with a preprandial or fasting plasma glucose of about 90 to 130 milligrams, and the peak postprandial plasma glucose of less than 180 milligram or 10 millimoles. We need to make more frequently self-monitoring of blood glucose associated with medical nutrition therapy, with a restriction of dietary protein to less than 0.8 gram per kilogram of weight per day. How or why do we need to optimize glucose control? There are several studies that have shown that with an intensive and better metabolic control, we can avoid, prevent, or delay complication of diabetes, especially diabetic nephropathy with less than half in people with type 1 diabetes, in less than 1/3 in people with type 2 diabetes, and in Kumamoto study with a reduction of more than 70% of diabetic nephropathy progression or presence of diabetic nephropathy. And in DCCT, it was more clearly seen a better result due to intensive control. And this was seen even after 10 years of finishing of the study in EDIC study, when the group that has the conventional diabetes therapy was continuing to have worse outcomes related to diabetes microvascular complication, in this case, even for the reduction of glomerular filtration rate. As for the treatment of diabetes, we need to weigh the benefit and the risk of hypoglycemia, because with the reduction of glomerular filtration rate, there are a lot of medicaments that we need to stop or to halve their dose, maximal dose, as it is the case for metformin, that for a glomerular filtration rate of less than 60, we need to half the dose, and for we need to stop the metformin if the glomerular filtration rate is about 30 or less than 30. As for the other medicaments, we can see that repaglinide we can use in any stage of chronic kidney disease. And as for the GLP-1 or DPP-4 inhibitors, we need to keep in mind that there is a clear risk and contraindication for the use of them at the stage of 3 or 4 of chronic kidney disease. The control of hypertension is also important, with the goal to have a hypertension of less than 130 to 80, and in people with diabetic nephropathy as with more than 1 gram per day of proteinuria, the target could be even lower, 125 to 75 per patient. Always being the first therapy choice, ACE inhibitors or ARB blockers therapy, when especially with the combination with hydrochlorothiazide or spironolactone in these patients. There are a lot of studies showing that if we use ACE inhibitors or ARB blockers, we have reduction on cases that need dialysis in people with diabetes for ACE inhibitors and for ARB blockers. These are just 2 studies using captopril and irbesartan, but there are also a lot of other studies. There are some data that reducing salt intake less than 2 grams per day may help slow progression of diabetic kidney disease. What about the low protein diet? The American Diabetes Association suggests diet of various energy intake depending on the patient, but with the advancing of the renal disease, we need to restrict the intake of protein as much as 0.8 or at maximum 1 gram of protein per kilo of weight per day. And in this way, we can retard the progression of nephropathy. And even in this case, it is underlined that dietary salt reduction may help slow progression of kidney disease in both type 1 and type 2 diabetes. And the same is true for alcohol and smoking, because a lot of our diabetic patients are also smokers, about 25% of them. And the maximum quantity of alcohol, it's 2 units for men and just 1 unit of alcohol per day for women. And in this way, we can decrease the inflammation and we can slow down the progression of kidney disease. There are also a lot of studies showing that if we use the statins, we have a better glomerular filtration rate during the years. That's why the control of diabetic nephropathy is related to all this. Another point is, do we need the nephrologist? Yes, we need a close contact with nephrologist, especially for the stage 3, 4, and 5 of chronic kidney disease. And because in some studies, about from 8 to 28% of diabetic nephropathy, diabetic patients need to go to renal biopsy. And especially we need to have a close collaboration for people with diabetes who have an early onset, lack of retinopathy, and early nephrotic syndrome. In 2 observational studies made in Bristol and Glasgow, there was seen that there was a significant reduction in rate of glomerular filtration rate in first year after referral, half in the Glasgow study. And there could be different reasons: intense follow-up, better blood pressure control, more ACE inhibitor use, and removal of nephrotoxic drugs. That's why it is important to have a good collaboration with nephrologists. And we need to keep in mind also the cost. For dialysis in United States, the cost is about $70,000 per year, while in transplantation, it costs about $15,000 per year. So probably it's better to slow the progression and after that to try the transplantation instead of dialysis. How can we prevent diabetic kidney disease? Maintaining a good blood pressure with ACE inhibitors or IRB blockers as first-line choice, having a good metabolic control, avoidance of potential nephrotoxic substances, especially non-steroidal anti-inflammatory medications. How can we slow the progression? There are some proven interventions, as we already mentioned here: control of blood sugar, strict blood pressure, certain medicaments that can be used, studied but inconclusive dietary protein restriction, lipid lowering therapy, partial correction of anemia, and vitamin D administration. So, as conclusion, we may say that diabetic nephropathy is a common condition placing a major burden on patients, our society, and healthcare resources. It is treatable and I could say preventable. Blood pressure control should be very tight, and ACE inhibitors on IRB blockers could be first-line therapy. Glycemic control should be optimized, and patients with advanced disease, deteriorating function, or atypical presentation should be seen in collaboration with a nephrologist. As MacArthur has said, that the history of failure in war can almost be summed up in 2 words: too late. I should say that in medicine, to prevent is better, and I should say cheaper, than to cure. Thank you for your invitation.